All right, awesome. Thank you. And we'll go ahead and get started.
Morning, everyone. My name is Grace Markley. I'm the Beneficiary Advisory Council Chair for the record. And just wanted to point out in advance, my apologies, my voice is a bit froggy, so it might be difficult to hear me, and I may have to staff a little bit if it goes. So on behalf of the Nevada Health Authority Division of Nevada Medicaid, I would like to call this meeting to order and verify that this meeting is being recorded. Today's meeting agenda for the Beneficiary Advisory Council was posted on October 8, 2025 on dhcfp.nv.gov and at notice.nv.gov. We are going to take a moment to pass it over to our administrator, Ann, for an introduction. Would you like to do?
Absolutely. I just want to say welcome, everyone here in person and those online. Really appreciate you taking time. I know this week is a funny one with the holiday tomorrow, so thank you for spending your Monday and what feels like a Friday with us. We really do appreciate you making the trip and taking the time out of your days and work schedules and busy lives to be here. For those in person, I want to point out a few housekeeping items. Emergency exits are on both sides of the hallway right outside our room. The bathrooms are down the hall to the left, and the code is up here on the right. If you need glasses to read it, I do too. So it's nice and small, but I promise we can pass that along if you need it. Want to thank our colleagues at Health Plan of Nevada and Sean and Bruce and team for providing our refreshments today. So please encourage you to get up and grab some coffee or juices or bagels at any point throughout the morning. And also want to thank whose idea was it to have it in this edition? One of our BAC members had recommended this, and I thank you. This is a beautiful space for those who can't be in person. We're here at the Historic Westside School. I'm really thankful for the staff and team here for their support in making this happen. So with that, I will turn it back to you guys. I'm looking forward to the discussion.
Thank you. Refer to the engaged feedback checklist from our first meeting. And I'd like to remind all BAC members that this is a safe and respectful space for everyone. Just a quick note that agenda items may be adjusted as needed. For today's meeting, we'll be switching items 9 and 10 to review the administrator's report before moving into the presentation portion of the agenda. Now on to agenda item 2, disclosure of any conflicts of interest. Please disclose any conflicts of interest you have at this time.
Yes.
Azraella, can we hear from you?
I'm here. Can you hear me?
Yes.
We can.
Oh, great. This is Azraella speaking for the record. I do have a conflict of interest. I have a hearing that I have to attend at 10:30, so I will be signing off, but I will be back for the MAC meeting.
Thank you.
I wasn't quite able to hear what she said.
She has a hearing at 10:30.
Okay.
Off for a little bit and we'll come back.
Okay, thank you, Azrael. We've noted that. For roll call agenda item, may I ask for support to? Maybe please take over for roll call to save my voice a little bit.
This is Nadia Flores-Rosilas for the record. I'm going to go ahead and do roll call. Administrator Ann Jensen.
Present.
Bill Sims.
Present.
Azraella Rivera.
Present.
Jessica Thunderbird. Pilani Queen. Brooke Blanco. We have Brooke Blanco online. Okay. And I think that's everyone. So it looks like we have met quorum.
For the record, it has been verified that we've met quorum. Let's move on to agenda item 4, public comment. If you would like to make public comment, please raise your hand or type public comment in the chat. and the last 4 digits of your phone number and/or your name will be called on to begin. Please state your first and last name again for recording purposes, and you would have 3 minutes to speak. Do we have any public comment?
No comments.
Okay. Now for agenda item 5, committee member introductions. Would like to thank all of our committee members for being here today. This is, as Ann said, this is a very wonderful location. I love a historic building, so thank you. And I would like to please get an introduction from each of our committee members. And can we start with Bill Sims? Just a little, just a hello and what brought you here?
Hi guys, Bill Sims for record, and I'm here because I've been on the bad Medicaid in total for about 15 years of my life, and so I'm just here to see what I can do to help making the bad Medicaid better for any patient that uses it.
Thank you, Bill. Azriela.
Hi, I'm Azraella with my baby here. I'm sorry. I will be the vice chair for the MAC program. My baby just fell. It's great to be here. I was interested in making a difference in my community, and that's why I joined the committee.
Thank you. Jessica, it looks like we have a new member. Yes. Jessica Funderhoff, are you online person?
Jessica from Berkeley, and I'm here because I like to see my people, like, sorry, like I see my mom's doing for large portion of the back.
Thank you for being here. Thank you for joining us, council. Kaylani Queen.
My name is Kaylani Queen. I am a single mom and a Medicaid recipient out here in Las Vegas. I've been out here since I was 3, so technically like the Vegas native. I am also a Medicaid doula as well, so the other one, so I'll stay here a little bit later. And I do have a client that is due tomorrow, so if I have, I'm so sorry, I'm gonna have to get up and take the. Just wanted to put that up.
Thank you, Kaylani. And Brooke, welcome. Did she join us online? Okay. And for the record, I am Grace Larkins. I'm here as representing really my daughter, who is almost 11 years old, and she has complex medical needs and is a beneficiary of Medicaid via the Katie Beckett eligibility option. I also work for the Nevada Center for Excellence in Disabilities, where I helped other families who have kids with disabilities and complex medical needs. And we have met Ann. Is there anything else as an introduction you'd like to say?
Yeah, so for those who haven't met in person yet, I'm Ann. I'm the medical director here in Nevada. I've been in this particular role since July of this year, but I joined the state Medicaid team last July to help lead our children's behavioral health transformation. I grew up in Oregon, so my family's from this area of the country, but I spent a lot of time in the Midwest and East Coast, so I was really excited to move back to Nevada and spend a lot more time outside and with my family. So really happy to be here, and just want to thank you all for being part of this. I know, especially during a work day, it's challenging to step away and take time to be here, but it's incredibly valuable for us to really hear your feedback and to learn the good things that are happening and also the challenging things that you all are facing, because there's a lot we recognize we can make better in this program, and we can't do it unless we hear from you all and from the folks across our state about how best to do that. So thank you again for taking the time and for being here, and don't hesitate to grab me during a break here during before or after the meeting to chat about anything in particular as well, but really excited that you all are here and appreciative of your time.
Thank you. Agenda items 6 and 7, discussion of August meeting minutes and vote on meeting minutes. The meeting minutes were sent to council members on September 11, 2025 via email for review. Is there any discussion on the minutes at this time?
Any discussion or edits?
Discussion or edits? Okay. I'd like to call for a motion to approve.
Do we have a second?
Sure.
Second
Hi.
Phil? Okay. And then we ask everyone else if they want to, if they want to vote yay or nay. If you want me to call them, I can call.
I'll third that
Oh.
with a yay.
Thank you. May I ask for a yay or nay for the members?
That will be Azra Ellis speaking.
Okay, at this time, agenda item 8. Here we have, you'll notice on our agenda, we have 2 different roundtable discussions. This is the first of those. And this one really can be a little shorter. If there's anything that we need to get back to, we'll have another chance to do so. But the intention for this roundtable was really just to open up that discussion amongst our members. You let us know what brought you here to this committee, but I think we'd really like to hear what are your priorities? Are there any particular issues that you have been faced in the past or currently as a beneficiary and would like to see addressed? So this is just a chance to get your voice in at this time. So this again would be great if we could just go from each member and if you could let us know what is your most important issues. So let us start with Bill Sims, please.
Excuse me, Bill Sims for the record. I think one big thing for me is whenever I go to my doctor, and when they refer me out to someone else, they don't always know if that doctor that they referred out to accepts Medicaid. So I think if there'd be something to kind of bridge that gap that says, hey, if we're going to refer you to someone, make sure it's someone that accepts Medicaid. So it's not a surprise when we actually go to that doctor and say, we're going to take you back Medicaid. So for me, that's a big one. Excuse me. Because I've been on, like I said, in the Medicaid for more than 15 years of my life. That is something I've come across probably hundreds of times every time I've ever had to be referred out to another doctor. So I just think if there's a way we can figure out a way to put it in like a doctor's system that at best it recommends specialties that accept Medicaid first. And then, go from there. But, so that's one big thing for me.
Thank you. That's great feedback. How about Azraella, please?
Hi there. This is Azra Ellis speaking. In the notes, I looked over the Nevada Managed Care Risk Mitigation COVID-19 PHE demonstration. I found that the world was not ready for a pandemic and what the risk related to those will look like at our society. So I appreciate that Medicaid is looking at that as well. I enrolled into most of the email services provided by those PowerPoint slides related to Medicaid, and I think that's important to be in touch with all the various subcommittees Medicaid's related to. My biggest concern that I would like to address on the committee is family planning and what it looks like to have a life of a family in Medicaid and all those benefits that are associated to family-related matters. I was a previous recipient of Medicaid for quite some time, and so was my family. The main source of our Medicaid via through mail was something that I got every semester, every quarter, and the letter was about my children's well checks. However, when I go to apply those type of well checks within the community that I'm in, they don't necessarily translate very well. And so if we can adopt policies that will be applicable in our communities here in Nevada, I think that would be the greatest approach to utilize the benefits of Medicaid and offer benefits to its recipients.
Is anyone able to just give us a summary of that?
Yeah, and we recorded it, so we can listen to it back as well. Because I know it was a little hard to understand a little bit, Australia. It was cutting out a little bit. So
I do apologize for that.
No, that's okay. That's not our stuff.
This is Monica Schiffer. I'm in the room, and if I could please just verify that I heard you correctly. With the communications that are going out to the communities, are we looking for not only plain language in those communications, but also an idea of the type of communities, the culture of the communities that we're communicating with? Is that what I heard?
Yes, so for the child health checklist, child visits are supposed to be with their PCP or their pediatrician at the first month, and then it has like the months thereafter. However, in some communities, although Medicaid enforces this type of visitations with our primary care providers, it doesn't actually translate to the fullest, meaning doctors may just want an annual visit for their HMO to hit certain saturation. And so we're not actually able to get into seeing our child's or our baby's child care provider. Now, we did transfer into another care provider that is more welcoming to that, but we did hit some stumbling blocks regarding those issues.
Thank you so much for the clarification.
Okay, thank you very much, Azraella.
To learn, full as expand, the others, and also be a part of activities, educating others on what benefits offer.
We're going to be traveling into Reno tonight, and we're going to.
Also, long-term care of multiple facilities for people who need extended stay for a like a heart issue.
Okay, yeah. What you want to make?
One thing that I've been having that I have, and I know there's a reminder list on the website that I can look into. And a few months ago, I was looking for a specialist, a mental health provider for children for my daughter. And I called some providers on the lead list, and I want to say it took about 10 calls to find somebody that actually accepted Molina, that is still located in Las Vegas. A lot of the numbers that were on there were providers that are no longer here in Vegas or no longer accept Molina. So there's a lot of confusion on why their names are still on the provider list. So just kind of making that list a little bit shorter, knowing that these providers are still out here and they're still accepting Medicaid patients is really important.
Thank you. That is an informative. Right, and we still do not have Brooke. Okay. All right, so what I have heard from our members at this time, forgive me if I don't sum these up perfectly, but we will look back again as this is recorded. Bill, it sounds like when we receive referrals, it would be helpful if it was also understood or disclosed at that time if they actually accept Medicaid, so that we don't waste one's time. Azraella, the policies and communications specifically regarding children's well checks, it sounds like it's important to have those line up with what is actually practical and feasible for the providers. Jessica, you're here representing mothers and here to learn how to help to educate others, as well as some interest in long-term care. And Kaylani, the provider list, I think that in-network provider list, to ensure that it's up to date on the website, and also I think that provider list is robust. We have enough providers in the area and regions for all of the various specialties. Okay. Thank you very much for all your feedback. And we get to move on to our agenda item 9, administrators report. So I'm very happy to again introduce Ann Jensen, our administrator for the Division of Nevada Medicaid, to provide her administrator's report.
Absolutely. Yeah, so thanks all for having me. As I did last at our meeting back in August, I'm going to share some top priorities and things that we're working on here at Medicaid, so you all have some information on that. I'll pause then, ask if you have any questions, and we can go down any particular, talk about through any details on any of those. And then I'm going to share one kind of spotlight project each quarter, each time we meet. And so today we're going to talk about something we're doing called value-based care, which is really about how do we pay providers for the types of clinical outcomes we want as patients. And so I would love to get some ideas on some two major areas that we're focused on, and we'll share some documents with you all as well. So to start though, I want to give a few updates on our top 3 things that we're focused on here at Medicaid between now and the end of 2025, which is hard to believe, but it comes very, very soon. So first on that list is the implementation of statewide managed care. And what that means is right now, Medicaid patients, as we talked about back in August, that live in Washoe and Clark counties have their Medicaid coverage usually delivered through a health insurance company. So like Lana mentioned, through Molina or through HPN or through any of the 5 or the 4 plans we currently have. Starting in January, we have a new contract period, meaning the state signed a new partnership with the health insurance companies to give Medicaid services. And instead of just being in Washoe and Clark County, it's going to be across the whole state of Nevada. So we talked a little bit about this back in August. I'm really excited for my colleague Maria to share more about what that's looking like on our end and get your feedback on a few particular items as well. But what's really important to know is that for everyone in the state, we're currently in an open enrollment period. So if you are a member that's with a managed care plan right now, you have until December 26th, the day after Christmas, to pick which plan you'd like for the next year. After that time, once you pick that plan, you have 3 months to change your pick. So you can always, in the first 3 months of the year, make a different choice. For folks that live in our rural and frontier counties, so anywhere outside of Washington Park, they will be assigned one of the 2 plans that exist in those counties. It's either going to be Silver Summit or CareSource. You'll find out which plan you have in December, and then you also have that same 3-month period to switch your options. I'll note there are a few groups of people that still will not have their coverage through managed care. It'll still be through fee-for-service Medicaid. I know Bill, you talked about that before. That's not changing, but it's for folks, primarily folks with kids, all kids on our plan, and then adults without children as well that are not part of our waiver programs. They're all part of that managed care. So in terms of, Jessica, I really appreciate your comment about how do we communicate this and share with our community. I think the really important thing to share about this is if you're in a Medicaid plan right now, you should get to pick who you'd like for next year. If you don't want to change, you don't have to do anything. So that's another option as well. But making sure folks have a chance to take a look online. Each of our plans do a lot of work to offer kind of really creative benefits to support folks in things that are maybe even beyond healthcare. So a Sam's Club membership, or transportation options like a Lyft voucher, grocery store gift cards, things like that. So it's always helpful to take a look and see what there are offerings there are. And to Kalani's point, trying to call your doctors if you're going to make a change to say, hey, I'm thinking about changing my plan. Do you still accept this insurance? That's going to be a really important piece too. So that's the expansion of statewide managed care. I'm happy to answer any questions for folks on that piece before we move forward. So anything on managed care changes that you guys would like to hear? Yeah, I'm excited for Marie to share more. She's going to have some marketing and materials about what we're talking about open enrollment, and we'd love to get your feedback on a lot more info to come. So stay tuned for a lot more on that topic. But number 2 priority is related to the new health insurance plan that we're going to launch January 1st of next year. So we like to do big things on January 1st every single year. And it's related to a new health plan for kids that have complex behavioral health needs or that are involved in our foster care system. So the goal is those kids right now may be part of a standard managed care plan or maybe part of our fee-for-service program. I think we can all recognize the experience. I really appreciate you sharing. It's really hard often to get access to these mental health services that we all know our kids could benefit from. And the way that all of our systems interact, we don't always talk to each other very well or very clearly. And so the intent is for this health plan to give full coverage, so medical benefits, behavioral health benefits, pharmacy benefits, transportation, for kids that are part of a foster care program or have other complex needs to try to make that process a little bit easier. So each kid will be assigned a care coordinator that works with that family, foster family, bio family, whoever is caring for that child to really help them navigate the system, including their school, including the foster care system, potentially for folks that are involved in justice facilities, right, including that system as well, helping them really ensure that they're able to get access to the care. So what's important in this priority is that we have to go through a process as a state to pick who that plan will be. And so what happened last week is we posted on our website a really long 300-page document we've been working on for over a year that describes exactly what we're looking for in terms of the health plan that would help serve these kids. And so folks across the country now have until January 6th to submit their proposal of how they would meet those requirements and bring something to our Nevada community that would align with those goals. So that period is happening for the next about 60 days. Then in January and February, we have a team of folks from the state, from our Medicaid team, from our child and family services partners, from our counties, from our legal aid colleagues as well. We have a whole host of folks that will be reading those proposals and figuring out how that aligns with what we're all looking for. And then the goal will be to make a selection of who gets that bid and go through a full contracting process and start getting that set up early next year. So that way we're all ready to go come January. So if you're interested in learning more about what that plan will look like or what that includes, we have all of that information on our website. You can go in and read that 300-page document if you want. It's probably not the most exciting reading, but it's important stuff. And we also have some more summary materials as well on there. We'll also be making a webinar that will be shared very soon that has some more information as well. But that's a big milestone that happened since we last met, so I wanted to share that with you all. And I'll pause there. Any questions on kids' behavioral health, things that you want to see included in that plan that you want to make sure we're thinking about as we go through this?
Hi there, this is Azraella. Can you hear me?
Yes, Arella.
I think that 300-page document that you mentioned is an impressive feature. I'd love to see it in practice and how that looks like. I've read a lot about adoption and how we fail our kids in that system, and they grow up without having a sense of community. And so if we can translate that sense of community to our adopted parents and what that system looks like, and I think that would just be a dream come true for a lot of kids. So thank you for doing that.
Thank you, Esmeralda. I appreciate you sharing that. And I think that aligns well with the goals of how do we provide support for kids navigating a really complicated time of life, and how do we build that community of advocates that are helping them navigate it. So thank you for that. I appreciate it. Anything else on that? Okay. So let's talk about the third priority here. So number one was managed care expansion. New 2026 contract. Number two is about our specialty managed care plan, which is the fancy word we're calling it. And then third is really related to implementing new laws, both federally and at the state level. So I talked about this back in August. I know there's a lot of information right now about Medicaid and news nationally. So I want to share a couple updates on our end. The first is related to the government shutdown. So while that impacts a lot of us across a lot of different areas of our community, the good news on the Medicaid front is that it is, as an essential program, it is not impacted by the shutdown right now. So our payments are still coming from the federal government. I can still talk to all my colleagues on the federal government side to help get things approved or work through challenges that we have there. So we are continuing to move forward, even though we recognize there's a lot of disruptions that we all are facing through the shutdown, but I wanted to hear that first, that the Medicaid component is not impacted right now, which is great. Number two is related to the new federal legislation related to Medicaid. So I gave an overview again back in August. There's a lot of changes to the way that we determine who is eligible for Medicaid if they don't have kids, and they're kind of joining the plan as an adult by themselves. And so those come into effect. We have some time. It's not for a couple years until those changes really hit. So there's a lot of work we're doing kind of in the background right now to try to pull together some initial decisions for input from our community. So I expect at our next BAC meeting, we can likely share a little bit more information and start to get feedback, particularly on the way we help notify people of any changes to the way that they get their coverage, right? I think the most crucial piece that we all kind of share and focus on is how do we help people maintain access to whatever coverage healthcare they're eligible for? And the way we talk about it is going to make or break most people's ability to be able to access, right? And so that's one thing that's a real priority for me for the BAC is to get your feedback on all the ways that we communicate about our programs. I think we often use a lot of Medicaid language that's not super clear to people, and there's a lot we can do better about how we talk about our work and the benefits that folks have access to, and the way to get eligible and stay eligible and all those pieces. So know that there's a lot of work in the background on the federal legislation side. I know there's also a lot of discussion related to funding cuts in Medicaid. And what's really important to know there is it looks different for every single state across the country because of the way the state has designed their program. One benefit of the way that Nevada has designed our program is there's not as much money coming in through the mechanisms or the pathways that they've created that are changing with this federal law. And so there's fewer impacts to our budget right now than other states may be experiencing, or that you're hearing about as you have friends or family members that may be in states that are having to make more urgent changes to their program. The one area that will be impacted, and this is something that we've shared before, and I think I probably mentioned back in August, is our kids' behavioral health program is funded through some money that we get from our hospital partners, and that the rules of that are changing a little bit with these federal laws. And so what we're looking at is how to continue all of our children's behavioral health programs that we planned with just more creative ways of using funding that may be coming from different sources. So that will all play out in about 2 or 3 years down the line, but that means we're starting now to try to figure out what that looks like. But we look forward to bringing you some ideas that we have and ways that we're planning to address it for your feedback. But I wanted you to hear that as well. That there's not any immediate, not any short-term impact to our Medicaid budget, which I'm very thankful for. And so we're continuing to really focus on how do we make sure people continue to have access to care and that providers receive their payments for services in a timely manner so we can continue to run this program as we So any questions on the federal side before we move to the state legislation side? Yeah, Sean.
I just have a general question. And I should probably know this,
Okay.
but
No dumb questions, especially when it comes to federal law. Yeah.
is there a targeted grade reading level that you are using for your website?
Yeah, great question. So what we're held to in terms of federal law and state law is a 5th grade reading level. I will say, I believe all the materials on our website are at that level, but that's a relatively recent, it used to be 9th grade and it's now changing to 5th grade. So we're making sure that all of our materials align with that. So that may look different than it has to.
Okay, so follow, your is where it sits. in
Okay. That's a good flag. My understanding is that the state itself is held to 5th through some recent legislation, but I will have our team double check that.
Okay.
And we can work towards alignment long term to make sure those are right. Because yes, it's a real key area of focus of how do we make sure we communicate.
What we've heard a lot today is education, and that comes with health literacy, and that comes with understanding what you're reading, and it's hard. If it's hard for us, you know, and I'm in the business of healthcare, then it's hard for somebody who's not in the business of healthcare, just trying to get healthcare. And so I know I was reading something on the website the other day and I didn't understand.
Yeah, exactly. I think, and even if it is in a particular grade level, it doesn't mean it's always using words that we hear in Nevada use regularly, right? Like it's really important that the way we communicate is super specific to our community here. So I appreciate that flag. We'll double check on I'll pull the citations on those as well from our team to make sure that I'm speaking correctly. But as always, if there's things that you all are reading or seeing that aren't making sense, we'd love for you to be the first person to email it to our team and say, hey, what does this actually mean and how can we talk about it better? Because I think that's the type of feedback we really need. And if you're feeling that way, then I'm sure there's someone else who's confused by it too, right? And so how do we find ways to try to correct those things pretty quickly and make sure it's communicated? Anything else on the federal changes?
Hi there, this is Azraella again. Can you hear me?
Yes, we can.
Okay, so from personal experience, I have a 12-year-old who was on Medicaid, and as our salary increased, so did his premium from Medicaid. It initially went from like $25 to $50, and then I felt like if I were to reapply to Medicaid, it might have been even higher of a premium. Is that the kind of federal regulations you are talking about with our children on what age each child receives a managed care program within Medicaid? And if you can give us a little bit more insight on what it looks like for families, I think I appreciate that from a personal experience.
Yeah, thank you for sharing that, Azraella, and absolutely. So I think what your child is likely enrolled in is there's a lot of different front doors to how people get access to the Medicaid program. And those front doors look different depending on a particular family's income and kind of where things are at right now. So to your point, as incomes change over time, those front doors may look or feel a little bit different. So whenever there's a premium involved, so if you have to pay money every month or every quarter, that's likely through our Nevada Checkup program, which is a program where kids with families that have slightly higher incomes relative to the standard Medicaid eligibility front door have access to the program. And there are some requirements regarding contributions. And so to your point, those change depending on what those income kind of bands are or what the range is that your income lies within. And so what we can do as a follow-up with our team is we can pull that summary kind of schedule of what that table looks like and how that may shift over time, because I recognize that's a big change, and anticipating what that might look like when you go to reapply is super important. The federal changes don't impact the way that those premiums are calculated though. Those are based on kind of the federal income levels that we're all held to across the board, and those change I believe it's every October, those are reassessed, but that doesn't necessarily impact the premium amounts. That stays consistent. So what we can do is share with you the Nevada policy, and would love your feedback on the ways that we kind of summarize it on our website, even if there's other fact sheets or ways that we can try to improve how we talk about the checkup premiums and how those are calculated. We'd love to get your feedback on that. And I, again, appreciate you sharing that experience, Azraella.
Yes, because as a parent, it was a very new system for us as we aged out of Medicaid, I guess I could say that, because we weren't really prepared and we thought it might have been a scam. So if you could adjust on how the policy, like the billing aspect of those premiums are communicated to Medicaid recipients, I think it would give us a lot of reassurance as the recipients.
Yeah, thank you. I appreciate that. And what we can do is when we show that table, we can kind of show where those requirements are coming from. For the most part, the checkup program premiums are determined at a federal level, so it looks the same in every state. But we can also speak to kind of where there's opportunity for us to clarify our policy around it too, and we can figure out how we can bring that to a future BAC meeting as well. So thank you for that. That's a great
Thank you.
Yeah, absolutely. Anything else? Great.
I'm sorry,
So
and one more
Oh,
time, I just had an additional insight. A lot of so there was an agenda about homelessness and drug use disorder on our agenda for today. And I thought it was really important to include what the federal guidelines are for those programs, because I know it's going to vary by state to state, but is there an actual federal program, Medicaid related, for those type of individuals that will need access to Medicaid for a short time, but most likely are adults?
Yeah, thank you. And you have a wonderful musician in the background. So I just want to make sure I heard the full question. So it sounds like you were asking related to adults covered by Medicaid who are experiencing homelessness or struggling with substance use disorder. What type of federal Medicaid programs are available to them? Is that correct?
Yes, with the jargon that you were saying, that's the upcoming changes. I apologize.
Yeah, no apologies needed. No, I'm thankful for the question. So yes, there's a lot of detail in the federal law related to who these changes are eligible and who's exempt from the changes. So what you may be thinking about is related to, one of the big pieces is about work requirements, or community engagement is the other term. So adults without kids have to demonstrate that they meet these requirements in order to remain eligible for Medicaid. However, there's exceptions of who does not need to do that. And for the most part, folks that are homeless or experiencing substance use disorder would qualify for that exemption and don't have to meet those requirements. And so there's a lot of detail that we're waiting for from our federal partners about how they're going to determine that. But there's also some work that we can do at every state and kind of define what that looks like differently. So that's going to be a big piece that we will bring to our upcoming agenda item. Hopefully, we're expecting guidance from our federal partners actually as early as next week on that very topic. So I'm hopeful we'll have more information soon. And once we do, then we can start figuring out what a Nevada-based policy will look like. And so that will directly impact, of course, our patients that fall into those really important and vulnerable populations that we want to ensure have all the information to be able to navigate these changes smoothly. And so I'm really glad that you flagged that and look forward to bringing that to our next meeting too.
Thank you.
Yeah, absolutely.
Thank you, Ezra.
Great.
Yeah.
Yeah, please.
Question about hospitals, like, for example, when one person lives with their other, the father and mother's children, if they're under the same roof, and if they're not considered together, they have to be put in the same roof. So say, for example, in some cases, the dad might not want to participate in something that would be required. Why we will be penalized for that? Is that issue?
Yeah, that's a good question. So the way that Medicaid eligibility is usually determined is generally, there's a lot of really wonky exceptions, right? Is on an individual basis. So it doesn't matter who's living within your household, your individual eligibility, your child's eligibility is determined on their own. Of course, for kids, that they look at what their family members eligibility looks like. For work requirements, though, it would be related to a single individual person, and so would not require necessarily collaboration with another parent or someone else. Yeah, does that help answer your question?
Yeah.
Yeah, it's a good one. Yeah.
So in regards to the work requirement, when that is implemented, how, I'm trying to think of how to word it. Oh, sorry, go sense for record. Is the federal government going to allow each state to say what that work requirement looks like for people? Because that's one thing I do worry about is because I know I am disabled, but what if Nevada says, well, sorry, Bill, we think you can work, even though you are physically disabled, so guess what? You're gonna have to work 80 hours a month. How is that gonna?
Yeah, it's a great question. So the federal law has kind of a foundation of who this does and doesn't apply to. And so folks living with certain disabilities or people that are experiencing a number of different kind of medically frail conditions are automatically excluded from this program, no matter what the state decides, right? There's kind of a base floor, and then the states can then choose to add more clarification to that, right? They can add more categories of exemption or keep it as is, but add some little bit of clarity. So that will look different depending on the state, but there's kind of base requirements that will be in place no matter what state you live in.
Okay.
So what we can share with you all, again, what we're looking for from the federal government right now is what that base looks like. Because there's kind of very general language in the law right now. But after they pass the law, then the federal government, the Center for Medicare and Medicaid Services, they get a chance to give us detail on how they actually interpret it and require us to implement that. That makes sense. So that's what we're waiting on, which is a great flag. And that's something that we can bring and say, hey, this is what the federal government says. Here's our proposal for how Nevada is going to add to that in terms of those exemptions, and we can get your feedback.
Okay.
That sound good? Yeah, I appreciate you raising it. I know that's probably one of the most important aspects of any of this implementation is how that's defined. And also, how do we collect information that shows whether someone meets those qualifications, right? And how do we make that not too challenging of a process for people to navigate? That's a big area of focus for us. And what we're working on in the back end to figure out how do we use all the data we have access to right now to make that easier. So big area of focus.
Yeah, so you mentioned the exemptions with certain disabilities. Would that also include health disabilities?
It does, yes. Great flag. So it includes behavioral health disabilities, and substance use disorder and physical health.
Please, Heidi, for the record, I think that once we hear more guidance from CMS, we can probably bring that forth in like a presentation, like go over like, this is the guidance that they gave us in more detail and bring that to this group whenever that comes out.
Yes, absolutely. Yeah. I'm hoping it's soon. Every state in the country is hoping it's soon because it's just going to be helpful to us to make some decisions. But I get to meet with them in person in DC next week. So I'm going to say we really need this soon. So hopefully we'll get it. But that will be a real key area for us to get feedback from our community. And especially I recognize the way that people work and like what employment looks like in Nevada is different than what it looks like in California or in Missouri or in Florida, right? And so how do we design a system that really works for the ways that people are working where they can demonstrate that more easily? Because there is a lot more, for example, shift work in our state than in others, and how do we make sure that's reflected? So it really needs to be a state-specific, a Nevada-specific solution, but it has to first be based on what we're required to do federally, and that's what we're waiting.
And those requirements, or most of them, will go into effect in 2027?
Yes, January 1st, 2027 is the first date that those apply. So we have a little bit of time. I know that's going to come very quickly, but that's why we want to make sure we're not getting ahead of the federal government and have to change what we do once we get their guidance too. So always a little bit of a dance there.
Okay. Chris Larkins, for the record, in regards to the federal changes, Azriela had mentioned, the premium and so that would likely be through Nevada checkup. Is there not a requirement for premiums to be introduced to Medicaid members in general? And where is that? Where is that sitting and when would that start?
Yeah, great question. So there's a lot of little small components of this one big federal law. So that's a good one that I appreciate you raising. It's called, the word that people usually use to describe is cost sharing, but what it means, it's not actually premiums as much as it is when you go into a doctor's office. For certain types of services, doctors will be required to ask people to pay a certain amount. And that only applies to adults without children that are part of what's called our expansion population. So people that more recently have access to Medicaid. And that it's pretty big, again, than federal law. There's a lot of leeway that states will have to figure out how to implement this. So what I'm really committed to is figuring out how can we make this process as easy and clear as possible for our members, but also for our providers. This is new for them. They normally don't have to collect money from Medicaid recipients that are getting care. So this is a pretty big change. And so we're waiting again on federal guidance for those pieces. We have even more time. I believe it's summer 2028 is the first time that requirement will come into place. So there's a little bit more time on that piece as well. But there's a lot more information that we'll be working through. And as we have it on our end, we'll bring it to this group because that's another really big, crucial change for input, from our member community here. Yeah.
So those exemptions, with that also, right? It's a homeless.
Yes, would it apply for that piece as well? It's a great question. That's what we're waiting on information from the federal government on exactly what exemptions will look like. Also, what types of services. So things like primary care, behavioral health care, those are supposed to be exempt. But the kind of rules of who falls in and out of those groups is still a little unclear. So that's what we're waiting on. But what we can do is maybe pull together a summary of here's what's changing, here's who's impacted, and here's the decision that we can make within Nevada, right? Because then it's a little bit clearer on where we'll be asking for your input as we move to. That's a great question. Any other questions? This is a great discussion. Great slide.
Azraella.
Yeah, go ahead.
Sorry, Grace, I didn't mean to cut you off.
No worries, no worries. You go ahead and then Grace can go after.
Jessica pointed out something that brought some information to my attention. So I was a survivor of sexual assault and domestic violence, and my family was in transitional housing in order to become stable again in our lives. I was wondering if this vulnerable population is going to be considered for, I guess they would fall into the single mothers or the people with families that would be exempt. And because they're in transitional housing, they might not be able to have access to getting a job at the time because childcare falls upon the mother or the father that's being abused. What is Medicaid doing to address those limitations? If you have any insights, can you offer them, please?
Absolutely. No, thank you for sharing that, Azraella. And I really appreciate your focus on how do we ensure all members, including those that have really survived some trauma, able to access what is a really complicated system and get the services they need to continue to heal and move through that. So thank you for flagging that. To your point, these changes on the work requirements or cost sharing, those won't apply to people that have access to Medicaid because they're a parent of children. So for that particular subset of the population, they would already be exempt. But I imagine there may be folks that have experienced domestic violence or living in transitional housing that don't have children that are covered by Medicaid. And so this is an important flag for us to think about how does that align with some of the exemptions that we've seen and what that looks like on our end. I'll be honest, I'm not sure right now what that would look like, but this is a really important thing for us to take back. And I'll bring that. We have a meeting every Tuesday about this. And so I'll bring that to our team to think about how other states are grappling with it and finding ways to really make it clear who would and would not be required to meet those changes. Because I appreciate your point, especially when moving through transitional housing, those work requirements may be challenging. I will say we use the term work, but it's not just work that counts for these community engagement. School will also count as well as volunteering. So there is a little bit more flexibility there, but I recognize for many patients, that's still a very complicated process to obtain. So I appreciate your flag on that. And we'll see what we can do for thinking about for people that don't have kids with them.
Thank you, Azraella. Grace Larkins for the record. Just wanted to clarify if I heard you right. That there will be a summary pulled together of the cost sharing progress and updates.
Absolutely, yeah. So what we can do for our next meeting is maybe do a walkthrough of all components of the federal bill and kind of the impact people's eligibility and what the timeline is and what kind of where we're at within the battle in terms of implementing it. So we can do it for both cost sharing and for the work requirements piece. The last piece that we haven't talked about here is that I think we talked about this back in August. I remember a good flag from you, Bill, on this is Right now, folks need to submit paperwork to determine if they're still eligible for Medicaid every 12 months, as you all know. That month, 12 months comes quickly still. Moving forward, starting next summer, for folks that are, again, part of that adult population without kids that are not on our disability waiver programs, they'll have to do that every 6 months instead of every 12 months. So that's a doubling in the frequency of that. And so we can also talk about the process there and our path towards implementation of that. So those are the three kind of main categories. And so we can summarize those and hopefully have a lot more updates at our next meeting.
Okay, so then basically, like anyone disabled, you won't have to.
Exactly.
We'll still be every 12 months.
Exactly.
Okay,
Yes. Yes.
because that's what I was worried about, because it's like, I know like a lot of people think it's not that, sorry, maybe Wilson for the record, I know it's not like a lot of people think it's not that difficult, but it's like, but it's time consuming to be able to have to wait, make sure everything's submitted correctly, so, yeah.
Absolutely. And that's part of what we're doing is trying to figure out how do we make that process easier and better for everyone involved. And so I think I mentioned this last time, but we're building a new online portal that you can do on your phone or on the computer to submit that paperwork directly without ever going to an office or talk to someone on the phone, which we recognize can take a lot of time. So that will start to come into place as early as next summer, which I'm super excited for. So I think that will hopefully help on pieces of it. But I would love, as we get into building that, to get this group's feedback as well of, is it improving the things that you felt are the most challenging in that process? Because I recognize there's a lot of really complicated steps and however we can make that easier. Yeah.
Would they be able to enroll online and do that as well?
Yes, exactly. So the goal is for it to be kind of a one-stop shop for anyone who isn't on Medicaid but wants to see if they're eligible and can enroll there, but also for folks that are already eligible to submit the paperwork they need to determine if they remain. So it'll be applicable across the board. It'll also be connected to our exchange website. So for folks that are purchasing health insurance that aren't eligible for Medicaid, it'll connect there. So that way, as your income changes, you can be able to figure out what options best for you. So yes, I'm really excited about that one. And once we have prototypes of what it looks like and all of that, we'll be definitely, you'll be an early group to see and give us feedback on that, because that's a big change and something we're super excited about. Any other components on the federal side? I'll briefly touch on the state, but feel free to interrupt me anytime if you have questions on any of the things I shared before. So as we talked about last time, we have 53 bills that we're implementing from our legislative session this year. There's a lot of new changes that impact Medicaid, which is exciting. And so I will save all the excitement really for my colleague Casey, who's going to give a more comprehensive update about some legislative changes in a couple agenda items from now. So I won't steal her thunder there, but want you all to know this is a big area for us and will continue to be. We're actually still implementing things from like 2 legislative sessions ago, right? It's just an ongoing project depending on what we're required to do in terms of the timeline. So as always, I really appreciated hearing from you all which particular bills you're most interested in hearing about. So you'll see that first batch reflected in Casey's presentation today. But if there's other things that you're interested in, then we will keep bringing things that are coming to the forefront as we implement for your feedback. But no, this will probably be a standing agenda item forever and ever and ever in a good way. So I'm excited for you to hear more there. But any pieces on the state legislative side before we move forward? Okay, no worries. Feel free to interrupt.
Well, actually, sorry, Grace Larkins for the record. As we were talking about, so this is both federal, I guess, and state, the increased enrollment requirement for twice per year. Something that comes to mind is like Bill mentioned, the ease or lack of ease in that process. And this was brought up in a couple of different ways, but the procedural process, the forms, the applications, I'm hearing that those can be complex, right? And certainly not at like a 5th grade or even 12th grade level oftentimes. So is that something that, are those being reviewed? Is that something that we can, you know, look at as a committee and get some feedback?
Yes. Yeah, that's a great flag. They are being reviewed as it relates to that project where we're putting everything on the Medicaid Express kind of online platform. So what we can do is have that team plan to bring that here. The beauty of an online program is that instead of having 10 different forms, you can have one that if you answer a question in a certain way, that it drops down a couple of more questions, right, that you needed information on, but it's trying to streamline all that process a lot more than it already is. So what we can do is bring this to that group. I think it's a great idea. The other piece that will be changing on the enrollment paperwork front is for folks that are part of that adult without children population or category front door. There will be an additional form related to those community engagement requirements. And so getting your feedback on how that looks like and how that reads and how to clarify that piece will be another area of focus. So I think both of those we can absolutely do. There's certain things that we're required to ask in all those forms from the federal perspective, and there's a lot of really strict requirements on that. And then our state side, of course, this is connected to our STAT program and TANF and other programs, so that there's a lot of questions and different requirements there. So what we can do is provide some clarity on what the background is for some of those, why they're there, and how to get your feedback. So great question.
And I would just say that from the health plan perspective, it takes us a good 6 months to work with you guys to change the 834. And while we always want more information, we need to know about it really early, right? Because for us to get this all that information into our system and do something with it. So just keep us in mind on that really side.
Of course, absolutely. I appreciate that. This data sharing piece is probably one of the more complicated things that we ever do, and it's like the least interesting, but it's most important, right? And so how do all of our systems talk to each other? So thank you for raising that, Shauna, and definitely something that is early on in that.
The last 834 change, we didn't hear about it until after it was in effect, and so then we were kind of behind the jet all on that. Thank you.
Yeah. So,
Grace Larkins for the record. So if you mentioned that the forms for that online portal will be reviewed, do you know if the KDEC and return option forms will also be reviewed?
good question. So the Katie Beckett program and some of our waiver programs, because there's a lot more complex information that we need to collect, that's kind of in our phase 2 of the Medicaid app. The focus on Medicaid Express to start will be for kids and parents of children and adults without children that aren't part of those populations. So we have a little bit more time here, but I do anticipate that we'll have a chance to review that. And I know my colleague Heather, who I see on the call here, she's spending a lot of time with her team thinking through that Katie Beckett eligibility process to really figure out ways we can streamline that, even independent of the Medicaid Express project. So that's definitely something that we can add to the list for a future meeting to better understand how we can make that process. Recognize it's a particularly long one and could be benefited from some streamlining and fresh up.
Thank you. Yeah. One last question for me. The redetermination twice a year, as you were speaking about the, you mentioned that it would largely apply to adults without children and exclude those with waivers.
Mm-hmm.
So does that mean that adults with children would also be excluded?
Correct. Yes. Yeah. So parents of children are exempt from these work requirements, from the cost sharing, from those 6-month redeterminations. All 3 of those changes are really specific to only apply to the population of folks that are adults without children. Yeah. And that's the way the federal legislation is.
Thank you.
Yeah.
Yes. Do people have to provide proof of like these review a waiver of single vote, like for then
Yes, it's a great question. So the fancy Medicaid word for that is attestation, right? Are we requiring people to demonstrate directly that they're exempt, or are we using our own data to try to determine if people are exempt ahead of time? So what the federal law holds us to is that wherever possible, wherever we have data, we have to use that first before we go to anyone and ask for anything. Because that's really intended to make that process easier for people and to try to decrease the amount of kind of logistics involved. If we don't have any data that shows someone has a diagnosis of something that would make them exempt or otherwise would be exempt for any other reason, then we may have to go to them and say, hey, we think that this may apply to you. Is there any case here where you actually do need to be exempt? If not, then we would, those would be it. Does that answer your question? So for adults with, so parents with kids though, we know that in our system based on how you're well medicated, and so that would not, you wouldn't have to testify to that. Correct, and that's a real area of focus for us is, yeah, how do we make that process easier for people that are facing a lot of housing insecurity and other challenges, because asking for more paperwork is not the most direct way to do that for them. And so that's probably where having a diagnosis of a medical condition or behavioral health condition on a claim, if they've seen a doctor in the past X amount of time, that would make sense for that, and they wouldn't just. So, yeah, I appreciate that question, and that's definitely a key area of focus.
Chris Larkins for the record. How is the administrative support work for that? Is there enough staffing to process all of those?
Yeah, so that's what we're trying to figure out right now is make those estimates of what additional support we'll need and figure out where we go. We may have to go to the legislature in the interim before the next session. It's called the Interim Finance Committee. They manage if there's any extra money that comes in and out. That's pretty hard to do. There's not a lot of money available, but if we need to, we'll do that to be able to staff. That's another reason that I'm super thankful. We had already planned before this bill even passed to do this Medicaid Express, because the intent is really to free up time of our staff sister division that helps process these applications. If they don't have to help with 60% of the ones they do right now, that frees up time for them to help with these more complicated work requirements, components, and things like that. So the answer is yes, it will take more staff time. We're trying to figure out how we can do that with the existing staff. And then if we need to, we may have to go to the legislature to ask for more funding. Yeah. And the last piece I'll just add on that is part of the reason we don't have more details on those pieces, which I'm very eager for, is because depending how the federal government gives us guidance on how to implement it, it could look really different, right? So there's a big range of how complicated this could be and how much attestation is required. So I'm hopeful that within the next month or two, we'll have a lot more clarity on what that looks like, and then be able to start planning. All right. Thank you. This is a super helpful discussion on the top three. Do we still have time for you to talk through the value-based payment stuff briefly, or should we move to the next agenda item?
Yeah, let's talk about it.
Okay, perfect. So I'll just do kind of an intro, and then this is actually a document that we'll share with you for review afterwards if you have any feedback on it. But I'll give some kind of overall context. And this is a little bit wonky in terms of the way we talk about money in our healthcare system and policy. So stop me at any time I'm using words that are confusing, or if you want me to slow down and repeat it, because I recognize it's not super clear always. So value-based payment in the healthcare world, this is a term that exists kind of across the country. And it's all about how do we pay providers in our healthcare system based on the clinical outcomes of what their patients, of their patients, right? So we say right now in our healthcare system, we pay providers for every single action that they take, right? Every Band-Aid that's given, every surgery that's done, every medication that's dispensed, there's a payment associated with that. Value-based care is trying to move towards a model where instead we say, we're actually going to pay you if the patient stays healthy and doesn't go to the ER, right? Because you gave them a call and you helped them get the antibiotics they needed ahead of time, and they didn't have to go to the emergency room. And so because we save some money in the healthcare system, then that provider gets a portion of that narrative. And so this is a general trend that people are exploring nationally in our system. And so that's actually work that I did for a long time in DC before moving here. I've seen it be really successful to help ensure that we actually pay for the things that we as patients want to experience in our healthcare system. So what it looks or feels like to be in a really successful value-based care model could mean you have a really strong relationship with your primary care physician, and they're the one that you can call on a weekend or at nighttime and say, hey, do I really need to go into the ER right now? Or I need this support. How can we make sure that my kid can get access to the service they need right now versus having to go to the ER and wait a long time and have them go through that full process. It can also look like a lot more preventative screening. So these things that cost less money if we do them sooner, right? So cancer screenings and chronic disease management for people with diabetes or with heart disease, right? how can we do all the work when they are feeling pretty healthy to keep them feeling healthy, as opposed to that getting more sick and needing more costly and expensive care. And so that's what the goal of value-based care is overall. And before I talk about what we're trying to do here in Nevada, does that generally make sense? Do you have any questions on that kind of overall approach or kind of framing to our healthcare system here? Okay. So, and Connie, I'd love as we go through this as a provider as well, I'd love your input, because I think what's really helpful is what often we hear from our providers, I wish I got paid for the things that actually I know will help my patients, but don't necessarily fit within the model of how we pay for healthcare right now. So this is one way that we can get a little bit more creative. So in Nevada, what we're doing is we're kind of stepping a toe into value-based care. I will say states across the country are really different kind of levels of experience with testing these out. Nevada is a little bit newer. There's a lot of folks, including our partners at HPN, that have been working on this, which I'm really excited to and thankful that we can learn from their experience. But a lot of our providers, this is newer to them. And so what we're trying to do is figure out how do we as a state set a requirement for providers and for health insurance companies to participate in value-based care and just test things out. And so I think what's important is you'll see the document we're going to share, and hopefully you guys can all hear me. The document we're going to share is what's called a roadmap. It's describing, here's what we're trying to do here in the state as it relates to value-based care. It's about Medicaid, but it's also about all the other types of health insurance that fall within the health authority agency, which we talked about back in August. So it's people that are covered by the state employee benefits program, like me, right? It's also people that buy their insurance on the health exchange. How do we try to use the value-based approach to make healthcare better for people across all of those different types of programs, no matter who's paying the bill for your healthcare? That's a huge task, right? And so to try to focus it and to test things out, we need to get a little bit more specific. And so our health insurance company partners and our hospitals actually picked 2 areas of focus that we're going to be focused on in value-based care for the next couple of years. And those are maternal health care and care transitions. So maternal health care means everything from the moment someone finds out they're pregnant until probably a year postpartum, right? Because there's a lot of medical and behavioral health changes and things that our parents need as well as our babies need as well during that time. We are, I think, 48th in the country right now, in the 50 states, in our outcomes for moms and babies. And so we need to do something different, right? And so this is one area that we're trying to say, hey, if that process results in a really healthy baby and a healthy mom, we'll pay you more for that, right? And if you do some really creative things, we'll try to incentivize you to do more of those things. And so that's a big area of focus. Care transitions is probably something that may feel newer to people, but it's really important that it's about how do we help patients that are moving from a hospital or an ER or a skilled nursing facility? How do we help them transition back to their home or back to a rehab facility or some other place that's in a community setting in a way that feels a little bit more smooth? You know who to go to, you know what medication to take, you know which doctor to call for your follow-up appointment. All those things are really confusing. I've experienced as a patient not knowing where to go after I leave an ER or leave a hospital. And so what we're trying to do is help incentivize a little bit more coordination of all the people involved in that process to make it better for patients and to decrease how often people go back to the ER or to the hospital if they don't really need to, right? So those are the 2 areas of focus. What you'll see in that roadmap is we say, we want to do value-based care. We're going to do it in these 2 focus areas, and we want your feedback on specifically how we'll measure whether we're getting better at those 2 things. And so you'll see a list of measures, things like how many babies are born at very low birth weights, right? That's a measure of mom's health and success in pregnancy. That's one way we can measure it. But we can also say, actually, what we want to measure is how many C-sections are happening, right? How does that compare overall over time, right? There's a lot of different ways to measure, is something working? And that's what we want your feedback on. So our team will be sharing that document with you all after the meeting. There's going to be a lot of chances over the upcoming months to get feedback on those measures. Our hospitals are giving feedback, health plans are giving feedback, and the whole goal is for starting in 2027, there to be contracts between hospitals and our other providers in the community with the health plans that say, hey, this is what we're going to measure your success on, and we're going to pay you differently to see if we can try to improve those. So I'll pause there. Does that kind of framing make sense? Any questions or initial thoughts on that piece?
So, yes, Bill Sims for record. So I was just curious, so does that mean like if there are things that do come up, like, not necessarily that the doctor would be paying more for, the patient has to go to the doctor, but they won't be penalized for it, right?
Yeah, great question. So sometimes we talk about in the realm of value-based care, there's carrots and there's sticks, right? So carrot would mean we pay you more if something good happens.
Yeah.
Stick means you're penalized if something bad happens. Right now, we're fully focused, we're living in the world of carrots, right? But you got to start the process without a lot more penalties. Really successful value-based care though has a combination of both things. To say, once you kind of get your handle on how to do this and you build your process to call people on the weekends before they go to ER or set up that after hours nurse hotline, then as a provider, you may say, yeah, I'm willing to let you penalize me if it doesn't work, if you give me more money if it does, right? And so we can kind of raise the stakes, if that makes sense. The patient would never be penalized. That's the most important part. It's really about how do we pay the provider. The patient's experience is what we're focused on making better, but patients always will have the right to choose what they need in that case. And so it's really about how to make services available to patients that really better align. Does that help answer your question?
Yeah, so then on top of that, so would there be like exempt, like, if you guys do eventually end up going to both sides of the kissing, the sticks and the carrots?
Yeah.
I mean, like, would you guys look at that individual patient if it's something like a chronic illness where it just can't be?
Yeah.
It might not be able to be helped.
It's a great question. So the way, that's exactly right. So the way I mentioned there's quality measures, right? That determine like, is the care that we're giving getting better? And the way that we measure that, it's the goal is never 100%.
Yeah.
Because that's just not going to be possible or realistic. What we can instead set the goal on is maybe it's 5% better than it was in Nevada last year. Or maybe we are at the national average of how doctors do across the whole country. There's different ways we set those thresholds. But the goal is really to say, there's certain types of things or certain types of patients that may need something different. And we never want to set up a system where that's considered a failure. But how do we keep setting the bar higher and higher over time? Does that make sense? Yeah.
And Grace Larkin's here.
Oh, yeah. Okay, I think Alana had a quick question, and then we can.
Okay,
Yeah.
I think it's just the time, it's okay, we keep, sure, thank you.
An issue that I'm seeing in the regional health community right now is lack of financial support, especially for Medicaid patients. And a lot of the moms right now don't have transportation to go to places like patient sort of maybe CLC, and out of pocket it would cost $250 to have one come to the home. And a lot of my clients don't have the funds or means for that. It's vital that they get that support within the first few weeks of postpartum, so they're able to have a long patient and breastfeeding journey for their baby, and having that support, hopefully through Medicaid, providing an IPCLC to the home, a great benefit for maternal health, because that would ensure would help decrease the bit of postpartum depression in moms, and also reduce financial stress through having to outsource and things like that. So something that's really necessary now, especially with struggles I'm seeing with not having means of transportation. So
Thank you for raising that. I really appreciate it. That's something that we can take back in terms of looking at our reimbursement for in-home lactation consultants as well. This is something on the kids' behavioral health side related that we're trying to actually pay providers more if those services are delivered in someone's home. And so how can we think about maybe exploring that model on the lactation consultant side? So thank you for raising that. And I hear you on the transportation challenges side. That's a real key barrier for a lot of services. And how do we try to make that better? There's some things that we've changed about our transportation program, even for managed care next year. And I know our health plans are really focused on partnerships with Lyft, for example, or other creative ways to make that better for patients. So maybe that's something that we can also add to the future list. And we have a long list of things to cover at future meetings and get your feedback on what we've tried so far. And
Amazing, thank you.
that's also struggling just to get to the hospital for their birth because of
Okay, we do have one question from Azriela in the chat. just go
Yeah.
do that and then we'll move on to the next agenda item.
Absolutely.
Hello, I had some clarifying questions about Medicaid legislative updates regarding Assembly Bill 463, 514, 300, and 389. What is the single pharmacy legit program? What are some of the limitations for rural recipients who might encounter difficulty regarding having a single pharmacy for these prescriptions?
Do we have a legislative update on the agendas? Some of these questions could get answered there.
Yeah. Yeah, absolutely. I think so. All bills that you mentioned there, those are numbers that are burned into my memory. Those are all big important ones that we'll be talking about, that Casey will share more about. But I can just super briefly speak to Azraella, your question on the single pharmacy drug list. So it's what we're moving towards is a single list that all health plans will cover the same types of drugs across the board. It's not moving to a single pharmacy. So you can still get your medication from any in-network pharmacy. It's just what's covered is going to be more consistent, no matter which health plan that you're on. So I believe Casey may actually speak to that one, and we're happy to provide more details. I just want to give you that assurance that for checkup patients, for example, the list of what is and isn't covered or the pharmacies will not be changing.
Thank you. This is a great time to move on to our, this great conversation, great discussion. Thank you. This is a perfect time to move on to our legislative updates. So I would like to introduce Casey Ingris, the agency manager with the Division of Nevada Medicaid, to provide us updates.
Good morning, everyone. Can you hear me okay?
It's a little quiet.
Is that any better?
That's a little better.
Is there a way we can do that here?
You see it? Oh, okay. My notes.
Maybe let me turn my computer microphone off and I'll call in from my phone and see if that helps a little bit.
Okay, that's good. Thanks, Casey.
I'm also going to go off camera my internet's been a little spotty to save bandwidth, but I did want to come on and introduce myself so you can all see my face. But I'm Casey Ingris, the agency manager over our federal policy and compliance teams. And if you'll give me just a second, I'll call in and see if that sounds better.
Thanks, Casey.
I'm going to join you. Cheers. So good. No, you're fine.
I always do.
Exactly. That's the good stuff.
It was like the first thing we started to do when I woke up this morning.
That's great.
I think it's great.
No, she was up on
All right. Can you all hear me a little bit better?
Yeah, okay.
Hi, Casey.
Hi. Can you hear me okay from here?
Just give us 1 second. I think everybody wants to grab a little refreshment really quick.
Okay, perfect. Just let me know when you're ready.
Okay.
Here, you want to take that mic and like this thing. But is your easy like, because you know, is there, I can look your chance if there's anywhere that says like, here's a list of like participate. So people on like regular Medicaid like that.
Yeah.
And not like That, yeah. So you might get. Yeah, straight, yeah.
Yeah. Actually, that mail. This is on your.
Yeah. Okay. Yeah. Well, yeah, I was just curious, because I know like Amazon and, like, Amazon, but too, things like, just want your Medicaid, but then that makes me think, well, you're not only paying for service.
As you just like to speak.
Yeah, yeah. Yeah. I know now, I know. Yeah, yeah, I mean, so that's like, it's right, I mean, because I know I wanted to play as part of this, that's the thing that like I've ever been like, for that's that name, like, weird stuff, or Medicaid, not. Okay. Okay. Yeah. Okay. Yeah, just on. So.
Yeah,
Okay.
absolutely.
Okay, cool.
Yeah, thank you so much. Appreciate it. Yeah. 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 That's why I'm like, oh, good. That's my. Oh, I appreciate it. No, it's very fair. We don't need to that much.
All right, everyone, we're gonna go ahead and get restarted. Took a little break, but, yeah, we're gonna get started on the presentation from Casey.
All right, just making sure you can hear me still.
Yes, again.
All right, perfect.
Oh,
So again, my name is Casey Ingris. I'm the agency manager over our federal policy and compliance teams. And I just wanted to thank you all for the opportunity to present some of our updates on where we're at with implementing some of the bills that came out of last session. And before we get into that, when we talk about implementation, whenever Medicaid is adding new benefits or services or making significant changes to benefits that we already have, we always have to get federal approval so we can get that federal funding. And the way we do that is generally by a state plan amendment, which is our state plan is sort of our contract with the federal government.
Really sorry, Reese Larkins here for the record. Hold on for one moment. Would it be possible to move that speaker forward so we might hear it better?
Yeah. Sorry, Casey, still having loud enough.
I think it's
No
just
problem.
So maybe our.
See if it can get this moved a little bit.
We just want to be able to hear you.
I don't know if it's coming from, or maybe here.
I thought it was coming through.
No, that's a lot.
I think it's coming from the laptop.
I see.
Okay, Casey, do you want to test it out one more time?
Yep, can you hear me okay?
It's better. A little better. Yeah.
Okay.
As loud as you could be, Casey, is great. I appreciate it.
Thank you.
Okay.
Ready for it.
So you ready?
Yes.
Okay. So when we talk about getting federal approval for new services or benefits or making changes, we have to go through some steps to get that federal approval. Sometimes we have to update our state plan, which is our contract with the federal government that explains what we offer, who those services are given to, what we pay providers for that. And so a lot of times we have to submit a state plan amendment. Sometimes we have to submit a waiver if we're trying to waive existing federal Medicaid rules so that we can provide specific services or to a specific group of people. And so you might hear some of those terms throughout these slides, and I just wanted to explain what those terms mean. Okay, next slide. So the first bill we have an update on is Assembly Bill 36. And this bill requires that if a provider wants to appeal an action taken by the division, that they do so no later than 30 calendar days after the division has taken the action, unless extenuating circumstances exist. This time frame is already in practice in Medicaid policy, but it's now become part of Nevada law. And this bill is effective January 1st. And currently where we're at with that is we're developing policy to sort of explain what extenuating circumstances are and what they mean. And so that policy change, you'll see that being adopted at an upcoming Nevada Medicaid public hearing. But one big thing to point out is that this bill pertains specifically to provider requests for a hearing, recipient requests for a hearing. They already have that 90 days that exists in policy. And so we just ended up putting that in Nevada law with this bill. If you have any questions on any bills as I go through them too, please feel free to raise your hand or throw a question in the chat. And then we'll also have time at the end for you to ask any questions that you might have. Next slide. Assembly Bill 463, this one makes some changes to our prior authorization process. And this bill actually reduces the response times to prior authorizations to 2 business days after receiving the request. And this impacts both the fee-for-service and the managed care benefit delivery system. So it'll be the same whether you're on fee-for-service or under managed care. And this bill is effective January 1st, 2026. And where we're at right now is we're making updates to our prior authorization processes internally, and talking a lot with our managed care plans and our fiscal agent who processes our fee-for-service prior authorizations. And we're also doing a lot of research on how there's a federal rule that came out to improve prior authorization processes at the federal level. And so we're doing a lot of research between both of those regulations and making sure, trying to figure out what crossover exists, where those rules overlap, just so that we can make sure that we're compliant with both pieces. And so for this bill as well, we'll be adopting changes to our Medicaid Services Manual related to prior authorization processes at a future public hearing, and updating our billing manuals and things like that as well. Next slide, please. Assembly Bill 514 adds coverage for rehabilitative residential mental health care services as a place to go for people with complex behavioral health needs before they return to their community. This bill is also effective January 1st, 2026. Nevada Medicaid held a public workshop on October 14th to gather feedback from stakeholders. And I've included a link to our webpage that has the materials from that public workshop in case anyone wants to go see what was presented. I believe we'll have the minutes up there too eventually at some point. And so we're also drafting a state plan amendment that will be submitted for federal approval by the end of December 2025. And then we'll also be making updates to our Medicaid Services Manual at a future public hearing. Next slide, please. Senate Bill 54 will add coverage for medical respite services for individuals experiencing homelessness. This bill also is effective actually January 1st, 2027. And this is one of those bills that we have to submit a waiver rather than a state plan amendment. So the 1115 waiver process, also known as a demonstration waiver, this is a different process for seeking federal approval and federal funding to support those services. It is a little bit longer of a process to submit an 1115 waiver. And so where we're at right now is before we submit that 1115 waiver application, we have to hold 2 public hearings before submitting that and also include a 30-day comment period. And so right now we're working on trying to select a vendor to help us prepare that application because it is such an extensive and complex process. We really want those subject matter experts that are familiar with doing that to help our state submit an application that's likely to get approved and will serve our needs. And so we're thinking we can provide some updates on that at a future MAC and BAC meeting once we get closer to actually submitting the waiver application. Next slide, please. Senate Bill 185, this bill allows family members to be paid for personal care provided to certain children with a chronic illness or disability. This bill is effective January 1st, 2027. And right now what we're trying to do is figure out whether this bill would require a state plan amendment or a waiver. There's a lot of thought that has to go into that and knowing which authority we have to ask for that federal approval under. So we're really in that beginning stage of researching how we go about getting federal approval for this bill. And we can provide additional updates too as we move forward with the implementation for that bill. Next slide. Senate Bill 300, this bill will increase the amount that Nevada Medicaid pays to providers for certain medication administration for individuals with an opioid use disorder. And it also expands certain providers that can provide services at a federally qualified health center. There's a couple different effective dates for this bill. So July 1, 2025 was the FQHC provider expansion, and that's has been implemented already. And then March 1st, 2026 is the effective date for the increased rate that we're going to pay providers for that medication administration. And so we're drafting our state plan amendment right now for that rate increase. Next slide, please. Senate Bill 389 requires that coverage of prescription drugs be managed by a single pharmacy benefit manager. Ann touched on that a little bit before this presentation, and I think she answered the questions related to that, but if not, please feel free to add some additional questions in there. And so this bill is effective January 1st, 2030, so it's a pretty big lift, and we're in the very early stages of the process to find that vendor that's going to become our single pharmacy benefit manager. Next slide, please. Okay, and I think that was our last bill. And I did add some slides here so you all can keep updated on the most current information. So there's a listserv that you can sign up for to receive notifications via email of new initiatives, public meetings, and state plan amendments. We also have our public notices and meetings page where you can find links and details to our public workshops, public meetings, public hearings. And we also have a new state plan amendment page. And so whenever we submit a new state plan amendment to the federal government, we upload a copy of it to this website. And we also send an email notification out through our listserv to notify you that we've uploaded a new state plan. And so that page, you'll be able to view all of our state plan amendments that have been submitted. You can also send us comments after you review them and tell us what you think about those state plan amendments or give us any feedback there. And then you can also view the state plan amendments that have been approved on that page as well. And I think now we'll open it up for questions.
Bill Sims for the record. I actually had a question about AB 463 on prior authorization. So is that, unless I didn't hear it or I forgot, is that going to include with pharmacies, like for prescriptions? Because that is like, something else I talked about back in August is having to get prior authorization, because there are just times like a patient can't wait, forever on, the back and forth between the doctor and Medicaid to get prior authorization from the doctor who authorized it to begin with. So is that going to include pharmacies as well?
Yeah, thank you for that question. I know that the federal rule carves out pharmacy, so the new federal rule doesn't apply to pharmacy services. We're still researching how this bill might impact pharmacy services from the state bill, from AB 463. I'm not sure if we have any of our pharmacy staff on the line, but I do believe currently, at least under fee-for-service, I think the response times for those pharmacy PAs is already in line with Assembly Bill 463, but I may need to get that clarification and follow up with you after speaking with our pharmacy folks, unless, Ann, you have any additional information to add.
And Sean's working on implementing right now, so you're gonna speak to that?
So, because Sean knows for the record, so for the pharmacy portion of it, already in the managed care contracts is already a requirement for a 24-hour turnaround time.
Okay.
So this 2-day turnaround time won't impact that. We're not gonna go longer. Just because this 2 days here, we've had a 24-hour turnaround time for the last 4 years in our contracts.
Okay.
But Bill, for you on fee-for-service. Yeah. Right, exactly. So that's where to Casey's point, we're figuring out what changes we need on our side with the company that runs our pharmacy benefits, like which is the R on it. So it may look or feel a little bit different for fee-for-service patients than it does for managed care, and there's a lot we're learning from our managed care part. Definitely appreciate it. That's an important one to get turned around fast. And I think, well, it is pretty fast right now, and that's what maybe Casey we can add to the list of the pharmacy team to confirm with, and we can share what that average time looks like.
Okay.
So we can have that too.
I mean, that's why I'm just asked, because there have been times where, like, I've had to get medication for something on a Friday, but because it's a business day, when they reach out to the office, it's closed, and then, waiting to get hold of the doctor over the weekend, which I'm not saying is impossible, but then you have to wait for them or for your pharmacy, whatever, to then make sure Medicaid is doing everything, but the Medicaid doesn't do anything over the weekend because it's the weekend. So it's just a back and forth that just leaves patients up in the air. So that's why I'm wanting to see that included pharmacies as well.
Yep, absolutely. Yeah, it's a good thought.
Okay. And I do see another question in the chat about prior authorizations, if you'd like me to move to that one, or?
Sure, let's cover that one, and then we have a question in the room next. Would you read the
Sorry, what was
question?
that?
It is from Dual CI Church. Additional question regarding AB 463. Does respond to a prior authorization mean the MCO needs to issue a decision on the prior authorization request, or is it simply required to issue an acknowledgement that the request was received?
I don't know. Can you take an answer to that one? Yeah.
Yeah, that's a great question. So when Nevada Medicaid was going through the bill, we sort of looked at the federal requirements for how to communicate the status of a prior authorization and used that definition and applied it to respond here. And so respond means either an approval, a denial, or if the fee-for-service plan or the MCO needs additional information from your doctor, that is also considered a response. So within 2 business days, either an approval, a denial, or a request to your provider for additional information. And with that federal rule, that request for additional information to the provider, that notice or that status update will also be available to the patient, so that patients know when additional information is being requested from their provider.
Thank you. Do we have any more questions from members of the BAC?
Some more clarification.
Hey, Lonnie.
I got some more clarification, so.
Oh, okay. Okay, great. Thank you.
I have one question. Just the record, percent of SB 300. It says the opioid use disorder. What services that just provide like medicine only or like actual inpatient?
Good question. Casey, I can take that one first, and then can you repeat it? 700-300. Yeah, the question is, what services are we talking about for treatment related to opioid use disorder? And it's really specific to medication assisted therapy. So Suboxone, things like that. It's about the outpatient delivery of our services and helping those providers get paid more than they do right now. Yeah, great question.
So we'll have more providers in general.
That's the hope. Yeah, exactly. That's what we need. I know. So the intent is really to reflect, and also just the cost of delivering that has gone up over time. So, yeah. Question.
Yeah. We bill 514 with patients receiving the mental health. If they do have a child, start with money to go with receiving care. Do we know if there's any likelihood that there could be help with childcare within that facility? And so the child doesn't get second.
It's a great question. Casey, I'm not aware of how our team has thought through that one yet, so I think we should take that back. We're trying to sort through the policies related to this right now, so it's really timely feedback. And I know something that is challenging for any type of residential service is how do we ensure that we're supporting our full family units through that process, through that healing process. So I wish I had an answer for you now, but that's a great flag that we can take back to Sarah and Lori and our teams, Casey. And we're getting a second from Jessica here too. Yeah.
Do we have any other questions from BAC members?
I'm sorry, just to clarify what Keelan's question was, that they had a hard time hearing online, it was regarding SB 514 and providing support for children, for maybe parents who might be going through services, and what kind of support will there be for kiddos if there was some family support?
If the child could be family as well and have child care, so the child doesn't get.
Thank you. So I hope that was helpful for those online.
Thank you. All right. Thank you very much for that report. And we are going to move on to agenda item 11 with our discussion of statewide managed care, presented by Maria Curiel, Social Service Program Specialist 3 with the Division of Medicaid.
And give me 1 second. I'm going to play around with the audio really quick.
Sounds good. Good morning, everyone. Let me know when I'm good to go. Thank you.
Maybe muted.
Maria, can you hear us? Or can anyone online hear us?
Yes, I can hear you.
Just wanted to see if I can speak. Maria, can you hear us? We can't hear you, Maria.
Can you hear me now?
Yes, now we can hear you. Yes.
Perfect. Okay. So I'm going to share my presentation. Give me 1 second.
Okay, you want to share?
Yes, I can share if that's okay with you.
Yeah, that's perfect.
Okay. Let me know if you can see my slide.
Yes, we can see them.
Perfect. So good morning, everyone. Like already mentioned, my name is Maria Curiel. I'm a social services program specialist with the Nevada Health Authority, Nevada Medicaid within the managed care unit. And we completed this presentation to go over a few updates with statewide managed care implementation. So I wanted to make sure that we included a timeline just of key dates for members. The following timeline shows the process of when the request for proposal was released and the upcoming important dates for members. So in early 2024, the request for proposal was released to the managed care organizations. In October 2025, the members redistribution started. And currently in the month of November, post-distribution letters were mailed to members, and we still have a go-live date of January 1st, 2026. Member supports will be available to members January through March for the 90-day switch period, where members can go ahead and switch and select another MCO, with March 31st, 2026 being the close of the switch period. And for any people not aware of what the 90-day switch period, what that is all members have 90 days to switch managed care organizations following their initial assignments or selection. So if a member does not make a change within this timeframe, they will be remain enrolled with their assigned MCO for the duration of the coverage period. And there's always exceptions that may apply depending on if a member wants to switch and good cause and a good causes enrollment would apply if they meet good causes enrollment eligibility. With statewide managed care expansion, so what's changing? Starting January 1st, 2026, Medicaid managed care will expand to all counties across Nevada, extending coverage to an estimated 75,000 additional individuals statewide. This program will include 5 managed care organizations, which are Anthem, CareSource, Health Plan of Nevada, Molina, and Silver Summit. The care regions will be as followed. Members in urban Clark County will have the option of all 5 MCOs. Members in urban Washoe County will have the option of all MCOs, except Health Plan of Nevada. And all members in rural counties will have the option of Silver Summit and CareSource. Are there any questions before I continue?
No questions in the room.
Thank you. And I did want to include some of our efforts for engagement. We have conducted several outreach events throughout September and October, including statewide tours in collaboration with MCOs. Our efforts have focused on both community and provider engagement. Outreach activities took place at Boulder City Hospital, Pershing General Hospital, in Carson City, Elko, and Fernley, and these are just to name a few. We have also, we do have an ongoing outreach, and with our next upcoming event planned in UNR, November 20th, in recognition of National Rural Health Day. So we do utilize listserv communications to keep stakeholders informed and actively encourage questions and feedback through our statewide managed care email. The goals and objectives for statewide managed care. So when it comes to choosing a plan, residents have more options than ever. Clark County gets 5 health plans, Washoe County has 4, and there are 2 statewide plans that are expanding access in rural areas. So that means better coverage, more provider choices, and fewer hurdles for people in underserved communities. But here's where things really get exciting. So care coordination, this system is designed to reduce wait times, improve health, improve early interventions, prioritize preventative care, and ultimately boost health outcomes statewide. And to keep things moving efficiently, managed care organizations have to meet strict scheduling benchmarks so patients don't have to wait long for essential care. These new standards set clear expectations for primary care, specialists, behavioral health services, and more. So these are big changes with better access and stronger care for Nevada residents. Any questions before I continue?
No question.
Thank you. Some key components of implementation. So it's all about making healthcare smarter, faster, and more accessible. Statewide managed care is cutting through the complexity. Enrollment is based on zip code, meaning entire households can enroll together. So this approach does simplify coordination, reduces administrative headaches, and ensures consistent care for families. And one of the biggest challenges in Medicaid managed care is provider participation. Nevada's new statewide contract is incentivizing providers to join the network by reducing administrative burdens and offering clear reimbursement structures. With more providers on board, patients will have greater access to specialists, primary care, and behavioral health services statewide. And with care coordination, that isn't just about signing people up, it's about making sure they get the right care at the right time. So this system is designed to reduce wait times, improve early intervention, and prioritize preventative care, which are all key components for better outcomes. So CareSource and Silver Summit will serve rural areas beginning 2026. Both of these plans are required to meet network adequacy standards, offer telehealth parity, and same as in person, and they will be providing non-emergency medical transportation and deliver care coordination for high-need members. And there's always a question, why rural MCOs? So rural Nevadans do face unique health access barriers, provider shortages, long travel distances, behavioral health gaps. Managed care expansion is intended to improve equity, consistency, and outcomes across all regions, with the goal of strengthening access to preventative, acute, and behavioral health services. Any questions before I continue?
No questions here?
Thank you. And some of the rural access innovations are include electronic portal and member access points, expanding the use of telehealth and remote patient monitoring to bring care closer to home. Provider support will strengthen rural health clinics, federally qualified health centers, and certified community behavioral health centers to ensure consistent, high-quality care. Some of the MCOs are also having concierge services, which would include deploying kiosk navigators and liaisons in rural areas to help members locate and access providers. Local workforce development, they will be hiring and training locally with a focus on community health workers and peer support specialists. Community health workers and peer supports will be engaging trusted local voices, and they will bridge gaps in care, provide guidance, and build stronger connections with communities. Transportation services, they will continue through the medical transportation management, but will also be managed by the care plans. They will also now support travel, especially to improve access in rural areas. So for rural members, the rural members will contact your health plans to arrange transportation for care. And urban Washoe and Clark County residents, you will continue to schedule with the medical transportation management by calling the customer care center phone number that's listed below. And then I also did include the link so that you're able to access more information on transportation. Any questions before I continue?
No question.
Thank you. So the social determinants of health focus. So rethinking healthcare beyond medical care as a whole person approach. Healthcare is more than a medical treatment. It's about supporting the full spectrum of human needs. So Nevada is leading the way by integrating social determinants of health, addressing critical factors like housing, nutrition, and employment. These foundational supports are essential for long-term health and stability, recognizing that wellness begins well before a doctor visits. In lieu of services will also help reduce barriers by offering flexible community-based solutions, supporting their health, stability, and ability to thrive. And then by integrating social determinants of health into Medicaid programs to improve outcomes and promote equity, Nevada's approach reflects national best practices of proactive prevention, building a system rooted in stability, access, and long-term health equity. So together, these efforts are strengthening community partnerships and transforming how care is delivered. Some of the performance-based standards and compliance. So with the statewide managed care, improving patient access through clear benchmarks, transparent reporting, and data-driven decision-making. So timely care is priority. Scheduling benchmarks are tracked and enforced to reduce delays and ensure patients get care when they need it. And then the accountability is built in. So with a statewide managed care, the reports team will monitor key metrics like HEDIS for health plan performance, the CAP surveys for patient satisfaction, and then NCQA accreditation for quality compliance. So real-time reporting tools give stakeholders and the public visibility into appointment availability, provider networks, and satisfaction scores found in the link below. Any questions before I continue?
Questions?
Thank you. And then I did include my contact information if you have no questions now, but do have questions later on. These are both of our emails that are managed daily. And we do look at these emails and make sure that we do provide a timely response. So I did include both emails in the slide. And then just this brings us to questions. So do you guys have any questions?
Questions for Maria?
Thank you. And I did include a list of acronyms just because I know that, with Medicaid, there are a lot of acronyms. So that's in the very last slide. And thank you for your time. Have a great day.
Thank you, Maria.
Thank you.
No questions on the engineer. All super clear. Maria, that speaks to what a great presentation that was. Nicely done.
Thank you so much.
Yeah, that's great.
Thank you.
Okay, we have agenda item 12. This is our second roundtable discussion. I think this is a great time for us to bring up, let's see how we're doing on time. Okay, we're doing good. This would be a great time to bring up any questions that you may have, as well as future agenda items that we may want to consider putting on for next agenda.
No, different Medicaid plans are vendors at the different events in the community. I would love to see some more information on those services at those community events, and also some brochures on the health rewards programs that the Medicaid plan has, which would include things like money back for going to doctor's visits throughout community duration, or the baby's doctor's visits as well. So I would love to see this, each individual plan putting more knowledge about that out. So I can do less work in the community, bringing that to you.
I will just say that that is part of one of the major responsibilities of the BAC and the MAC is reviewing the MCO's marketing materials each year. The MCOs will all be presenting in our next, the Medicaid Advisory Committee meeting for those that will be staying for that. But also, I think around June is when we're hoping to bring all of the MCOs to present their marketing materials, and you guys can provide feedback. And not only on the materials themselves, but also how they disseminate those materials could be super helpful, I think, for them.
Not to put you on the spot, Sean, as the health plan representative here, but is there anything that inspires for you, or thoughts on how the team does it right now?
So we obviously, we bring our marketing materials for those discussions. I would say doula information would not be part of that because it's not marketing, it's health education and wellness. So it wouldn't be part of that package necessarily. I think that it would be great maybe for the MCOs to get together and do a presentation at one of these next meetings together about what we offer and what we provide. And I would suggest that we do it together so that you're not hearing the same things 5 times over. But just as a whole resource when you do it. I know I've seen it on others' websites. We have a section on our website about those services. And I'd be happy to get with you to make sure you have all of them.
I think it's so new in the community. See a lot of doctors don't even know about this benefits. I think just bringing more awareness to the recipients so they're aware
Yeah, and Shani, you bring up a good point of, it's the marketing materials is one piece, and then the health literacy and kind of the health wellness materials could be the other. And even though we're not required to bring our MCO partners to the table on that piece, that may be a really helpful thing to do both. Say, here's how we market the plan, and then here's how, once you're in the plan, once you pick your plan, here's how we talk about what benefits you have access to now, and maybe we could ask for presentations maybe of both pieces to try to learn best on how to communicate that, because it's a great flag. A lot of us don't know all the benefits that we have access to and how do we help patient advocate.
It's gonna be today.
Yeah,
Definitely taking note.
yeah, absolutely.
Looks like we have a question from Monica.
Hi, everybody, Monica Schiffer, Nevada Local Authority, Nevada Medicaid. I would like to know from those in the room and online, when we are doing educational type things, a lot of times we are providing that information on our websites. But since you folks are out in the community and seeing our, recipients and patients more often than we do, are paper flyers more advantageous for in that instance as opposed to being just online, or what would you suggest for us?
Well, I would love to see more paper flyers, but maybe possibly on the apps as well. Just to implement that, so people are. I will disclose as so patients in the community who may have mental health struggles or are going through like pregnancy who probably aren't going to log on to the website. Don't have to find something like go through their plan and know what the benefits are. So I think paper flyers and just having a benefits list on the app would be really beneficial. So there's really
Just like that, Chris, maybe, or.
That's right. How do you talk about it in a minute? Read it and see, oh, that's actually something that I would want or could help me.
Everybody understands this.
Yeah.
And also, do you think that there are events or community places where we could go or reach out or ensure our messaging are in those events? Please let us know. You folks might know different outreach areas that we could reach out to that may not be on our list. So that's also something to consider, and those for online as well.
Grace Larkins for the record. Monica, I think you bring up such a good point. I think it's something we could look at in the future. What is the most effective way to reach our beneficiaries, reach the population? Like you said, is it through online? Is it through paper? Is it through events and outreach? And I think that's really something we could add as an agenda item at a future meeting.
When sign out for patients sign up that they're pregnant, and then apply to their work template sent to them from their health plan, and listing the benefits that would also include like food restaurant and a yoga book, things like that. A lot of people aren't aware. It would be nice if maybe they could have that when they sign out for their pregnant, and also the benefits about that open works program.
Thank you, Kimberly. So I wanted to, Grace Larkins, for the record here, to point out we have a question online, although it is not from one of our BAC members. And so if you can please hold on those questions until the public comment section at the end. Do we have any more questions or comments from BAC members? I did want to bring up, there is, I was informed that the MAC is going to be looking at a work plan on how they want to structure their committee. And that's something that is going to be discussed at today's upcoming MAC meeting. So if that is of interest, I think it's important that we have an eye on that. And it also brings up the question of the structure of our committee, our council, and how we want to strategically kind of move forward and also effectively complement the MAC and kind of feed into the MAC what we would like to present as the Beneficiary Advisory Council. So if there is interest, we could include on one of our upcoming meetings, maybe an agenda item related to our Beneficiary Advisory Council work plan of our own, and we may put some put the little research we can do to see how we can best do that so that they're synchronistic. Does that sound like something of interest?
Okay, great. We can put that together as the BAC support team. That also will help us, right? When we're looking at the next meeting and the agenda for that meeting. What are the things that, you know, you all want more background on to be able to provide all of these great recommendations? And so like today we heard a lot about the federal changes. So bringing maybe something at the next meeting about HR1 and what we know so far is for those changes. I think we've heard about ways to market and we're kind of bringing that question forward for our next meeting agenda. And then like today we had the legislative updates, and I believe one of the members, forget if it was BAC or MAC, kind of laid out, you know, we should get some updates on a variety of bills that Medicaid is implementing, and kind of sent us like, let's look at these the first meeting, let's look at these the second meeting. So I guess what kinds of, are those helpful, those legislative updates, one, and then second, which other bills would you guys like to see the next time? Would you like to see any of the bills that we talked about again, and getting another status update on those particular bills for the next meeting? All of those things would be super helpful for us when we're shaping the agenda. And then therefore we're able to reach out to our subject matter experts and get them on these calls to provide the updates and get most of your questions answered, hopefully. So that would be super helpful. For the MAC work plan, I think we've had a section where they have like goals and objectives, and then kind of like based off of those goals and objectives, some deliverables that they'd like to have for their group. And then shifting that into the timeline of the meetings over the next year. So, for example, for I think second quarter meeting, we looked at the marketing materials from the MCOs and also our annual report, because that is going to be coming due in July. And so those are things that we'll definitely want to have on the agenda for that time. And then, yeah, any other things that maybe Ann and Medicaid is working on, any other big projects, we will definitely come to her for that to get some recommendations on the agenda. But if there's anything you all are specifically looking at to give recommendations on, we're more than happy to hear and see if we can get some of our subject matter experts to come on these calls and provide some background information so you know everything that there is to know on that particular subject. So, and I see that Azraela has her hand up.
Hi there. Can you guys hear me?
Yes.
Can you hear me?
Yeah.
Hello?
Yes.
Okay, nice. Azraela speaking. Sorry I had to get off there. I wasn't sure if my clarifying questions were answered in the chat. Were they while I was out?
Was that about the pharmacy?
I asked more questions related to the other bills as well.
Okay, can we, Jonathan, do you mind reading those? Maybe we can, I don't know if Casey's still on, but maybe Ann can try to help.
You're right, yeah.
Okay.
They were about the legislative implementation updates regarding Assembly Bill 463, 514, 54, 300, and 389. What is the single pharmacy nominated for the CHIP program? What are some of the limitations for rural recipients who might encounter difficulty regarding having a single pharmacy for the prescriptions? Moreover, opioid use disorder expansion, sounds like additional funds have been dispersed to meet the crisis of afflicting many families. I think those were regarding the legislation stuff. Then there was some more regarding more questions regarding key follow-ups at the state amendment. Looks like what is the checklist for the waiver application for community members who are experiencing homelessness. I believe we can say that AB 514, as many Americans need access to mental health, but lack this crucial step. You give an update regarding the October 14th, 2025 workshop and any new information regarding the services. If Medicaid can respond to prior authorizations within 2 business days, that would increase quality care for patients. What are the changes that Medicaid is adopting?
Yes, I'm happy to take some of those, and then Casey and team feel free to chime in. I know we have a lot of our subject matter experts on the call too. But thank you, Azraella. I really, as always, appreciate your very thoughtful questions on each of these pieces. So were you on when I answered the first piece on the pharmacy side?
Yes, I was there.
Yeah.
Great. I don't believe the rest of my question.
Right. Okay, so I'll start then from I think I answered the first 2, so let's talk about the opioid use disorder. I think a similar question to what Jessica had said. The state plan amendment is basically our contract between us and the federal government. And what we're amending is to say that we will pay more for the medication-assisted treatment for folks that are experiencing opioid use disorder. And so it's a relatively straightforward state plan amendment, thankfully, that just says, hey, we want to pay more for this. We believe it's an important thing that we need better access to in our state. And so that's the process that we're going through right now. On the waiver application, so I believe it's SB 54 for the medical respite for folks experiencing homelessness. The waiver application process to the federal government is actually a really extensive one. It typically takes between 2 to 3 years to submit because we have to go through a lot of steps to demonstrate that we are going to it's called a waiver because we're waiving the federal law. We're asking for an exception to the federal law. In this case, to pay for something that we're not legally allowed to pay for right now, which is this type of housing services, medical respite services for folks experiencing homelessness. So we have a whole team led by an excellent colleague, Deidre, who's on the call right now, who actually works on these waiver applications for our state. We've gone through this process before, but the application includes detail on what the services are, how will we implement it, and also how is this cost neutral to the federal government, which is a really complicated calculation, but something that's required here. So we're going through that process for the next year and a half, and that's why the legislative deadline is for us to submit the waiver application on July 1st, 2027. It's not because we don't want to do any work till then, it's that it will really probably take us about 2 years to get all those pieces together. And there's a lot of public workshops and information on that will happen during that time. So a lot more info to come on that piece. And then, let's see, AB 514, yes, I'm really excited for that step in this kind of care continuum as well. The workshop was to kind of walk through what the policy looks like on what Medicaid will kind of cover as part of that. There's a lot of detail there that I'm happy for our team that leads that to speak to. And so maybe what we can do is follow up is include the slides and the materials from that meeting for you to review. And then we can also include the contact information for the people that are leading that policy. It's one of our colleagues, Serene, who is an excellent policy lead on our behavioral health team. And so she can answer any more specific questions you have on that. And I think the last piece is on prior authorization. Yes, Medicaid will be required to respond to prior authorization requests within 2 business days. And as I think Casey mentioned earlier, respond means approve, deny, or ask for additional information, really specific detail from medical records. And so all of those changes are going through right now. That requires us to change things in our data systems and the way we process prior authorizations. It requires us to hire more staff to be able to review those as well. There's a lot of changes that we're doing at Medicaid for our fee-for-service program, and that each of our plans are doing on their side as well to be able to meet those requirements. So I know that's a ton of info, but is that helpful to answer your questions or any follow-up pieces on that, Azraella?
Thank you. Yes, I was at that workshop, so I was wondering if any new updates regarding these services have been implemented.
I see. Great question. So right now, our team is essentially incorporating all the feedback we got in that workshop, and then there's going to be a public hearing. I believe they're taking that to a December public hearing, but we'll double check on that time frame and we can follow up there to formally adopt what will be an updated version of the policy based on that feedback.
And do we know what the demographic for our homeless community looks like and what kind of checklist we will need to, apply that waiver for the federal government?
Yeah, so in terms of demographics, it's a good question. I don't have that off the top of my head, but it's data that our team has and we can take a look at it. I know will be part of our application. That waiver application is for us to apply to the federal government and say, we want to pay for this, will you let us do it? Once we get that approval, there won't be necessarily an application for folks to get access to the service. It'd be like anything else where the provider has to determine that someone meets the eligibility criteria, but if so, then they can get that service. So it'll be a little bit less formal in terms of folks getting it. It'll be just like getting a specialty visit with a specialty provider or something like that. And more detail on kind of who will meet those qualifications will be part of our policy that we'll be developing in the next 2 years. So a lot more details to be ironed out during that time. Does that answer your question?
And to follow up, I know homeless people not only have issues with housing, but also transportation. So will that be included into the welfare of providing services for them?
It's a great point. So this service will be specific to the medical services and kind of that housing, transitional housing they'll have access to while they're recovering from a medical procedure. But what we can really include in our policy, and this is good feedback, is a very direct line of connection with the transportation services they have available through their plan, through their Medicaid plan, right? So everyone has access to transportation services that can help them get from that hospital to the medical respite house or location. And so we can make sure that we require those providers to work really closely with whatever transportation provider the patient has and also with the hospital during that discharge. So short answer is this waiver won't pay for transportation any differently. That will still exist as it does right now, but we can add some detail in our policy to make that connection as smooth as possible. Does that help?
Yeah, that's wonderful. Thank you for giving us additional insight. Now, you were talking about marketing. I've been seeing ads of "This is Medicaid," and I love that because it actually shows what people on welfare look like, and they look like working people. And that is a big misnomer about our general society. They don't understand that Medicaid recipients work. And I love that you guys market it just like that.
Thank you. I appreciate that. And I don't know if I've actually seen that specific one, but I know there's a lot of really good marketing both within Nevada and nationally to try to help folks better understand what is a really complicated program and also an incredibly diverse one, right? That serves people across our country with a real range of backgrounds. So I'm glad to hear that fellow representative of your experience, Israela. Again, welcome feedback on how we can continue to share that message.
Grace Larkins for the record. One additional item we may want to consider adding to the future agenda is related to us. Maybe is talking about ways that we are able to stay informed and provide the best feedback. And one of those pieces being data. We might want to think about, is there any particular data that we would like to be receiving ahead of the meetings or at the meetings, or some of them possibly monthly? This could be related to, and maybe even a deeper understanding of what information is. Are there surveys already being conducted, for beneficiaries or providers, or just so that maybe we look at how we could have access to those things. And one of those as well, if so some of these may be actually already internally being stored to other stakeholders. And so if there's something that, if there is materials that are released that really include updates and data sets to other stakeholders, is there some way to potentially access those as well? So just as something to add to future agenda. Do we have any other questions or comments?
Quickly, for future meetings or meetings next year, I think we have a couple of dates in mind, or are we just the months that we're thinking? The months, okay. So we want to kind of establish a cadence, a regular cadence for these meetings, whether that's the second month of each quarter or third week or whatever. I think when we were looking and what would fit well with keeping in mind of the annual report and the MCO's marketing materials, those usually come around June, I believe. And then they would need to be reviewed, and then our annual report is due July 1st. And so that would need to be reviewed before that deadline as well. And so with that in mind, we were thinking of doing the third month of each quarter. So it would be March, June, October. No, that's the second month. June, September, and December. And so is there like a, I guess, preferred week? I think obviously December is going to be a little bit tricky with holidays, things in mind.
Keep in mind that the MAC is meeting in June. The MCOs have to have the marketing materials in 90 days earlier. So that means we have to send them to sleep in March. So we can review them if there's a June meeting or maybe even but I just want to make sure the timing is there. Like we probably wouldn't have them at a March meeting or a January, February, March meeting. So it would be that next quarter.
The second quarter, yeah, that's what we were thinking, and that's why we thought the third month would be better.
Of the quarter?
Of the quarter, of that second quarter, so June.
Yeah, if you like it right before the MAC, or so that then you can have feedback for them or something like that.
I think the intention is to bring it there and have them provide the feedback, and then
it's you. So you would want to meet after that?
Bring it to Medicaid after, right? So
I would give it to Medicaid in March. March it's going to be 90 days ahead. So just need to look at the timing of.
I think we think about with the managed care team and map it out to see, because I think to your point though, once we get feedback from the MAC, make sure there's sufficient time to be able to incorporate that in materials for you all before they're distributed. So that is your thought that you would be too late for that, or the March is really fast? Exactly. Yeah. So finding the balance between at least long enough to give that 90-day window, you all sufficient time to create them, but then also enough time to incorporate those changes before they're released. Okay. Would September meeting though feel too late to be able to get that feedback?
So September,
given the open enrollment.
So here's your question about, are we going back to a single month October open enrollment next year?
This is the question,
right? Yeah. So if we're only doing that, that means that, so September, August, so that means that August 1st is the letter that the state sends out to the Medicaid members. So that means backing up from there, right? So the MAC has to be then like June in order us to have the feedback on that in March. So
right. I think the June is probably the right.
I think June is yeah, and I think that's what they've done in previous years was June, and so that's why we kind of picked that one. But I wanted to see if Jamie's on, or maybe Maria. If Maria's still on, I don't know if she knows.
What would be really good is if there was any feedback from the state, from this kind of group, the MAC, the BAC, on this year's open enrollment materials that they saw that we could then incorporate into making the next, right? Because if we see it, we see conceptually is what we submit to you. If you don't see the final product, you say, here's all the pictures we could use. Here's the messages we could use. So it'd be nice to maybe get some feedback on,
yeah, so maybe the first meeting of the year, we can do feedback on this open enrollment materials to inform the development March, and then we'll do a final review in June. Yeah, I like that. Yeah. Okay. Also helps address some of the proactively and makes it easier. Yeah, I like that.
I'll talk to Jamie about it and see what she thinks too. Thank you.
And regarding the future BAC meetings, are we going to continue to stack them on the same day just prior to the MAC?
I think that works best and what was preferred by most members. Unless anyone here feels differently, the BAC does need to meet before the MAC, and both the council and the committee both need to meet at least once each quarter. So it could be that the BAC meets the day before the MAC, or we do it how we've been doing it, the BAC in the morning, the MAC in the afternoon.
Yeah.
Okay. And that works for me as well.
And we think the times are okay, right? You're doing 9 a.m. to noon and then 1 to 4.
Yeah. Let's move on to our agenda item 13, public comment. If anyone would like to make public comment, please raise your hand, type public comment in the chat, and the last 4 digits of your phone number and/or your name will be called on to begin. Please state your first and last name at the beginning for recording purposes, and you will have 3 minutes to speak. Do we have any public comment online?
There is a public comment in the chat. I can read it out loud. So and I'm sorry if I'm mispronouncing, Dulcinea Church.
It's Dulcinea. Sorry about that.
No worries. Do you want to speak on your question, or would you like me to read it?
Sure. I just wasn't sure when the best time to post this would be. But yeah, I just wanted to briefly touch base. I was speaking with Jessica Houston earlier this year, back in April, and we had some progress. And I just wanted to revisit what the topic we broached back then, which was we see a lot of members. I am speaking from experience with a DME company. But we see a lot of members who find the current Nevada Medicaid 3-month trial as very cumbersome. A lot of the evidence out there does support shorter trials, and I wanted to know, there was an open letter penned, and I don't know if that's something that can be revisited or added as an agenda item in the future. But yeah, that's the long and the short of my comment.
Thank you for your public comment. We'll take that back. And we'll reach out. If you want to put some contact information in the chat, that would be helpful for us as well.
Absolutely. Thank you.
Thank you. There was, I think we're okay right now.
Yeah, I think we got it here. So thank you.
I appreciate you coming by.
Perfect. Thank you for the contact information. Is there any other public comment online? In the room?
No. Okay, well, that concludes our agenda for today and of the Beneficiary Advisory Council. So at this time, we will go ahead and adjourn our meeting and thank everyone for your time and participation.
Thank you all.
Thank you.
Thank you, everyone.